Thank you so much for attending the seminar today. It is my great pleasure to introduce Dr. Shlomit Schaal. Dr. Schaal is a clinician scientist and vitreoretinal surgeon, specializing in the surgical and medical management of complex vitreoretinal
You can't introduce me without reading, you know.
This is so much better than what I would. So, Dr. Schaal and I have a history. We've collaborated together for a few years now, and she's been an excellent friend to the bioengineering department, and so when the seminar series popped up, she seemed like a natural fit. And we're very fortunate today to have her and her team. Actually, they travel well, apparently. Here today to present some of the work she's doing with Dr. UofL-BE. Dr. Schaal is very distinguished in her career already, even though she's just getting started. She's accomplished quite a bit. She completed her ophthalmology residency at Rambam Medical Center in Israel, and then her PhD at the Technion Institute of Technology. She did her vitreoretinal fellowship here at UofL, and is currently an associate professor at the University of Louisville, where she is a director of Retina, director of the fellowship program in vitreoretinal diseases and surgery, and the director of diabetic retinopathy service. She's active in numerous societies. She's a prolific publisher. Her CV is the type where you want to sit down and pull up a comfortable chair and something to snack on and have something to drink while you read through it. And again, delighted to have her here today.
Thank you
and
very much.
Enjoy her.
Marty, for your graceful introduction. I have to admit that I've never given a talk to engineers, but half of my family are unfortunately engineers, so I know. So even though I have hopes, somebody may want to follow me and go to medicine, but that hasn't materialized yet. But I know from their discussions at home that I don't understand half of what they're saying, and so probably you may have difficulty in understanding what I'm talking about. What I would encourage you to do is that if anything is unclear and you have questions, make it more interesting for everybody, and just raise your hand. I'll be happy to answer anything. Another apology before we begin. I have a clinic starting at 1 this afternoon, so at 1 o'clock immediately, like Cinderella, we're going to disappear. And also there was a promise for lunch. I didn't see it. Afterwards, okay. Oh, we're going to miss lunch. We'll start with some acknowledgements. The work that I'm going to talk today is actually teamwork of many people that invest many hours in accomplishment. It's under the umbrella of the Coulter Translational Research Foundation grant. That Coulter Foundation is the reason I met Marty, started to work with engineers. Actually, it changed my life, really. It made my life much more interesting. And the team that I'm collaborating with is Dr. Ayman El-Baz team. Marwa is here. Ahmed, where is Ahmed? Thank you. Andy, and Ahmed Suleiman is here. Yes, good. And Ayman, you all know him. And my team, my research team is composed of mainly Agustina. Where is she? Here, thank you. And Thomas, I don't know if he's here. He's a medical student that is working on this project. Amir is a graduating resident now. No,
his cousin is here.
Cousin, Amir's cousin. All right, that was not planned, but thank you for coming. Amir is actually a graduating resident that now is a Retinal fellow in Chicago. And Dr. Sigford was my fellow, and now my younger colleague, a junior faculty in our department. Some more thanks for other people that are not involved directly in this project, but I'm going to quote some of their work. So our former fellow, Dr. Ahmed Oskop, is now in Illinois. Our current fellow, Wei Wang, you're going to see some of her work here as well. Our future fellow, Dr. Janelle Fassbender, she is here as well. And we have enthusiastic medical students that are working with some of our projects. We're going to cite some of their work here. And our senior enthusiastic fellow, Dr. Yusuf Begovic, which I guess he's working now?
He was coming.
Yes? Okay, so he's working.
Finding his way to
All right. So, and I have to disclose before I start that we have several patents on this technology. I have to disclose that we have some inspirations to become very rich out of this technology. We have support from Zeiss. They lended us the OCT machine that we did our studies with. And I have to disclose that I'm a physician, so I'm going to talk a lot about medicine and a little about engineering. So first of all, let's ask you if you all know what diabetes is, because we're going to talk about a way to discover or to quantify diabetes in the eyes. So just to make sure that everybody knows what diabetes is. So anybody wants to give the definition very quickly? Not one of the physicians?
Where the pancreas fails to make insulin.
Correct. So whenever you eat something, you need the hormone insulin to internalize the glucose into the cells. In diabetes, there is a lack of insulin, either from problems in the pancreas, that's mostly type 1 diabetes, or from resistance to insulin. The insulin doesn't work very well. So the glucose stays in the bloodstream. But diabetes is not just a disease of glucose in the bloodstream, it's also a disease of blood vessels. And we don't know exactly the connection, how this high blood glucose creates so many troubles in the brain, in the heart, everywhere else in the body, in the eyes, but it does. So just keep in mind, diabetes is a disease of high blood glucose, but also a disease that hurts blood vessels all over the body. Now, diabetes is an epidemic. It affects more than 29 million adults in America and millions worldwide. I just came back from the World of Pathology in Mexico, and they were talking about incredible numbers over there. If the current disease rates continue, 1 in 3 Americans will have diabetes by 2050. And this is just a map, and where we are at in Kentucky, we are now the number 6 place in diabetes in the whole country. And look at the trends, it's going up. Okay, so just so we understand where we are. Diabetes costs a lot of money to take care of. More than 399 billion in excess medical cost and in loss of productivity. What you have to understand that these are not older people that are sick and are handicapped because of diabetes. These are mostly young patients. And in our clinic, we see a lot of, 20s, 30s, 40-year-old people that are blind and they cannot work and they have to get disability. So this country spends more than $1,000 on diabetes health care for every American. So that's a huge number, and you can see the number worldwide, and it's increasing. Now, we're in Kentucky, so Kentucky, is famous for horse racing and bourbon and automobile manufacturing and bluegrass music and college basketball. But Kentucky is also infamous for several other things. For example, we're a top state for smoking. And now there is a lot of dollars invested in trying to get people to stop smoking. 67.5 are obese or overweight. And here is the smoking map of the United States. You can see where we are, actually the number 1 state for smoking. And here is the obesity map from 2015, and we are ranked there number 5. Louisville is actually the 8th fattest city in America, and I just Googled it and found that it contains more McDonald's per capita in any city, more than any city in the United States. So there is a lot of health problems in Louisville and in Kentucky, and we see these patients. Now, just to give you an idea of where this is going, this is until 2012, but I guess the graphs just continue to grow. This is the black line is the US numbers, and the red line is the Kentucky number. And here they asked, during the past month, did you participate in any physical activities? So you see that we were way behind. I don't know why the screen is dancing. Way behind, but it's still we are lower than the average in the United States. Yes, please, please, please. We're going to ask you questions in the end. Now, the obesity, which is defined here as BMI greater than 32, is also increasing over the years. And we have to find a way to stop that epidemics. So how can we stop it, or how can we address the diabetes numbers? So So there are things that we can't control. For example, diabetes is connected to genetic predisposition. So if you have a family member that has diabetes, you'll have an increased chance. So you can't change your family, you can't change that. If you are older, unfortunately everybody is getting older every day, you can't do anything about that. Race or history of gestational diabetes, diabetes during pregnancy, you can't change it. But there are a bunch of factors that we can change to decrease the rate of diabetes. For example, one of the easiest things to do is the physical activity. And I have a patient, this is the reason I wear this or whatever, and not just because it looks cool, because I also tell my patients, this is tracking my activity, and you should get something like this for yourself so you can see how much you're moving. And it's fascinating if you look on a regular day. I can tell you for myself, I'm very busy, I'm very tired, and then I look at the steps, I move 2,000 steps, which is nothing, it's less than a mile. So this factor is easily modifiable if you're aware of it, if you can get it through to the patients. Another thing is high body fat weight. We all know it's very hard to lose weight, but if people are aware that this increases their chance to have diabetes or to suffer from complications of diabetes, they can make more effort to lose weight. High blood pressure should be controlled, and high cholesterol should be controlled, and there's all medications for it. But patients need to understand that these are important things, okay? Now, I love this graph because it shows all the complications of diabetes, and what you can see that out of 9 complications, eyes are 3. So, usually in medicine we're not that important, but in this graphic here are so important, 30%. So there are several things that diabetes causes. One of the most important things is stroke. Stroke increases 2 to 4 times if you have diabetes. Another thing is heart disease. Have more heart attacks if you have diabetes, and also silent heart attacks. We just saw in clinic a lady yesterday, she was 45, and she had a heart attack, she didn't even know it. And when she went to the ER with a shortness of breath, they diagnosed at 45 because of diabetes. It's the leading cause of kidney failure, and also it causes peripheral nerve system damage, and as a result of it, it's the #1 leading cause for limb amputation. So you see younger patients without a leg with really severe troubles. And let's go back to the eye. The eye complications, I'm a vitreoretinal specialist, an eye doctor, so I'm interested mainly in the eye. Diabetes is the leading cause of new cases of blindness among the young population. I really love this when I say young population. Our chairman just reached the age of 74, so I always say, the young, he likes it as well. So this is considered young in ophthalmology. Most of our patients are older than that. So diabetes also causes 12,000 to 24,000 new cases of blindness every year. And these patients with diabetic retinopathy are expected to increase from 5 million to 16 million in 2050. So, our prospective future professional is secure. We have more and more people to take care of. Just because you are engineers and never learn anatomy of the eye, just so you get familiar with the area that I'm talking about. This is an illustration of the eye. The front part is the cornea. Have the pupil. The pupil is the hole in the eye where the light rays come through. There is a lens, and the lens focuses the light on the retina. The retina is the most important part of the eye, not because I'm a retina specialist, because it is part of the brain. There are nerves that capture the light and then throw all their axons into one big nerve called the optic nerve, and this optic nerve goes to the brain, and this is how we see. In medicine today, we can replace almost every tissue in the eye. We can replace the cornea, we can replace the iris, we certainly can replace the lens. This is cataract surgery. We have Dr. Smoiler here, that is one of the best cataract surgeons in town. So we do that all the time. But retina still unfortunately we can't replace. And if you lose retinal tissue, and especially if you lose cells in this most important area, which is called the macula, which is the center of the sight, then we cannot bring cells back and we cannot bring vision back. So it's most important to preserve this retina and take care of the retina. Now what happens in diabetes? Diabetes, this is a picture, actually a fundus picture where we take a picture from outside to inside of the eye to depict the retina. What we see is the optic nerve and we see the blood vessels, and this is the area of the macula that I was talking to you about. A lot of the patients with diabetic retinopathy have normal appearing retina. When you look into the retina, it looks normal. That doesn't mean that they don't have diabetic retinopathy. That just means that you cannot see it. You are limited by your examiner eyes, and you are limited that you cannot see very small molecular changes that are happening. But we know that even though the appearance is normal, there may be changes. We can detect them in ERG or other tests that can detect the functionality of the retinal nerves. So even if the retina is appearing normal, you can have still diabetic retinopathy. Now, if a patient has uncontrolled diabetes, the next stage of diabetic retinopathy is called non-proliferative diabetic retinopathy. What it means is that there is hemorrhages now in this retina. The retina small capillaries starts to bleed, and you can see these white lesions, which are actually lipid exudates. That fat is going to go out of the small capillaries and settle here in the retina. You can imagine that the patient that has this appearance cannot see very well, cannot see very sharply. Okay? So this is the this is Thomas, by the way, that I talked about him. Yeah, he's going to explain everything in the end. Now, if you wait long enough and you have diabetic retinopathy that is long enough in years, or you don't control your diabetes or your blood pressure, the next stage is the proliferative stage, and that's a very dangerous stage because blood vessels now, I don't know if you can see this here, loops of blood vessels, they grow outside of the retina. So they are not in the retinal plane, they are going inside the eye into the vitreous cavity. Now, blood vessels are not supported in the vitreous cavity, so they are very loose. So what happens? They bleed. So in this case of proliferative diabetic retinopathy, there's a lot of bleeding inside the eye. Blood inside the eye causes blindness as well. But if there is still one stage that is worse than this, and this is called the tractional retinal detachment stage. If we leave these blood vessels and we don't treat them, these blood vessels form scars. And as you all know, scars contract. When the scar tissue contracts, it pulls the retina, and the retina detaches from the place. So the retina here, I don't know if you can see it, it's wrinkled and it's out of place, and of course these patients end in blindness. One thing to really appreciate is that this is one of the few diseases that can cause complete blindness, which means complete darkness. A lot of the diseases that we treat as retina specialists cause partial blindness. For example, macular degeneration. It's a horrible disease, but patients are never completely blind. They can see the periphery, they can walk around. But this diabetic retinopathy, if we leave it untreated, it can cause complete blindness, darkness. And that's a horrible thing. Now, if we have diabetic tractional detachment that involves the center of the eye, we have to do something. And I'm a retina surgeon, so I'm going to show you what we do, because I love these videos and I hope they're going to play. So Wei Wang, our fellow, helped me prepare these videos, and let me show you. Hopefully it's going to work. No, it's not working. Well, unfortunately, that's, maybe. Hey, it is working. So what we're doing here is called vitrectomy. We are going inside the eye, and this is a diabetic patient with tractional retinal detachment. we are going inside the eye with very small instruments. This is forceps and a light pipe. And look at the retina, it's completely distorted. This is the optic nerve, and these are the blood vessels. But you see this tissue is inside the eye pulling the retina. So actually we're getting inside the eye and pulling it and taking it away. This is not an easy surgery to do. It takes a long time. And also, you may appreciate that you can hurt the normal retina as well when you're peeling these membranes. You can tear the retina, you can cause tears, and you can cause a retinal detachment just by doing this surgery. This is a unique technique because it's a very small instrument. It's called 27 gauge vitrectomy. We go inside the eye and do laser. This is laser treatment to the retina to keep the retina in place. Please don't throw up. You're fine? Okay, good. And then at the end of the surgery, the eye looks fine. It looks untouched. And for somebody that is as old as I am, you can still remember when I was training as a fellow, we didn't used to do these surgeries for these cases. We used to do a very big surgery with knives and scissors and stitches. And so this is kind of an excitement and a big progress in ophthalmology. This is another video. Let's see. No. Hold on. Let's show you this one. This is another video showing you the blood inside the eye in diabetes. See how much blood there is? But we're going inside the eye with small instruments. We're draining the blood, and then we're putting air inside the eye, and we're able to take the gel, take the blood, and clear the visual axis. So these surgeries really revolutionize the way that we take care of diabetes. But as you may appreciate, they are very expensive. It's not only our fee, but also the hospital fee, and also all these instruments that in this country we use and then throw away. This is very expensive. Okay, this is how we get out of the eye. The eye looks good. Okay, so that's a big advancement, and something just to share with you the trends. You have here the gauge of the surgery. The lower the number, the bigger the incision. So all these surgeries used to be 20 gauge, used to be with very large incisions. This is Dr. Dennis, is our fellow. 20 gauge, it used to be very big incisions. And look what happened. This is my cases, my own cases, okay? Because I'm a scientist, I like to graph everything that I do. So you see that the 20 gauge cases in here in red, where this is how I was taught to do. This is when I became an attending in 2008. Cases increases, but then stop doing them. What I'm doing now is mainly small gauge, 25 gauge, and this year, first time, we did more 27 gauge for these cases than 25 gauge. So surgery is becoming more and more complex and advanced. One of our resident now, but going to be our fellow, Dr. Fassbender, published a nice paper at the beginning of this year that created a lot of buzz, and I'm getting calls from the New York Times and things. What we said is that, we have this capability to save vision. Why are we waiting months and months and months and giving people injections and laser? Why don't we just, go to surgery, do the surgery, and see, if the patient gets better? So what she did is she collected, together with our previous fellow and a medical student, she collected all the patients that underwent vitrectomy surgery due to diabetes, due to blood inside their eye, and she calculated the time that they spent with low vision and calculated the area underneath the curve. The area underneath the curve is the time that patient didn't see well. And this was the time 0 was the time of the surgery, and then she calculated how much time they spent with good vision after surgery. She found something very interesting. She found that if you do surgery early, you spend a lot less time with bad vision, and after the surgery, you actually improve your vision. So these are the curves superimposed. The green is the immediate vitrectomy, go to vitrectomy soon, and the brown is currently the traditional way that people are waiting to do vitrectomy. And you can see that there's no statistical difference between the areas underneath the curve after vitrectomy, but there's a huge difference before. And also, if you compare the area underneath the curve before surgery and after the surgery, they are much better off after vitrectomy surgery. So this is kind of a new concept that we introduced, and we're getting a lot of responses and getting to have to respond to a lot of people that are asking questions. This is expensive. Why would you want to do it? Let's wait. The truth is that these are young patients and they want to see. If you had blood in your eyes, you wouldn't want to wait. You would want to have something done. And this surgery is relative. Yes, it's expensive, but relatively it's safe. We have a small number of operative complications because of the small technique that I showed you. So this is a relatively good way to treat things fast. Our senior fellow, Dr. Dennis, when he was a resident, he actually collected the data of how we improve the vision of the patients with our new treatment. This is a different complications of diabetes. It's called diabetic macular edema. And what you can see here is that the vision improved. This is all our cases that we did at all our patients at the Lions Eye Center that we can collect with diabetic retinopathy, how we treated them over the years. And you can see that our success in treatment over the years has improved. Their vision has improved. If you were a patient in 2004, you saw less than if you were a patient in 2014. So you had a better outcome if you came to our clinic in 2014. But in this paper, we also said, this takes a toll because we improve the vision, but there is a cost. What's the cost? Look at the number of clinic visits. People have to come more often so we can take care of them, either by surgery or medications, but they have to return, up to 10 or 9 times a year in average in 2014, whereas in 2003 they only had to come 3 times a year. And that reflects the overall healthcare burden that it keeps increasing. We have better treatment, but people need to see us more and more often. So after we talked about what is diabetes in the eye, how we take care of diabetes in the eye, one very smart man said, and I will probably slaughter his name, so you can just read his name. I don't know if you know him. He was a Dutch philosopher, and he said that prevention is better than cure. So everything that we do in medicine, and especially in this disease that is preventable, we are much better in investing in prevention than investing in trying to cure. If you don't know this philosopher, he also said something probably that you use every day, especially the men among you. This is what he said too. So very smart man. So there is a lot of effort towards screening for diabetic retinopathy. If we can remember that I showed you all the pictures that diabetic retinopathy goes from stage to stage to stage. It doesn't just appears one day and you're blind. No, it over years develops and progresses from stage to stage. So a lot of effort recently is invested in trying to catch diabetes in an early stage. Because the thought is if we catch it in an early stage, we can prevent the complications of blindness. So this is the recommendation of the American Academy of Ophthalmology that if you have diabetes, anyone with diabetes should come and see their eye doctor every year, once a year. Even though they see well, they have no problems, they have to come and see once a year because they may have diabetic retinopathy that is undetected. Excuse me? Okay, so early detection can reduce the risk of losing vision by 90%. So it's very important. But the reality is that when the family doctor tells their diabetic patient, it's really important for you to see your eye doctor once a year, the reality is that fewer than 50% follow this recommendation. And you may know it from yourself. If you don't have any symptoms, why would you go to see an eye doctor? Especially it's so uncomfortable to see us. We shine lights in the eye, we dilate the pupil. You know, no one likes to see us. So they don't go. So people don't go, don't follow. So that's a very big problem. So now there are efforts to develop telemedicine, something, it's called teleophthalmology or teleophthalmoscopy. There is an effort to develop software that people can be examined or taken picture of their eyes at their primary care physician's office. And these pictures, this is a clinic, these pictures will be taken and then there will be a report uploaded to a server. The server, they're going to be a very wise retina specialist or an eye doctor or somebody that is going to read the report and then send the report and say either this is okay or this is not okay. Actually, there are several companies competing on this market. The problem is that all these telemedicine efforts are concentrated on the fundus photography. So all the technology is basically taking a picture, and then if you're a retina specialist, you need to identify, normal or abnormal. But if you remember, when I started the talk, I told you that this may be abnormal, okay? You can see something that looks normal to you, but it's abnormal. So our approach with the bioengineering department over here is to take use of something other than fundus photos. Something that is going to be more objective and less dependent upon the retina specialist or somebody else that needs to interpret these pictures. And so there is a technology called OCT, or Optical Coherence Tomography. What it is a machine that uses light and reflection of different layers of the retina. And what I did here is just demonstrated how this area that we call fovea, this area that is the most important vision, sharp vision of the whole eye, is represented in this optical coherence tomography. And what it is basically almost histological cut of these layers. So the retina has at least 10 layers of different cells that are aligned, and it's very complex structure. But this OCT technology has become our standard of care. In the retina clinic, everybody gets an OCT. Now, the problem is this is an abnormal OCT, and you don't need to be a physician to say, well, this is not the same as the picture that we saw before, right? Let's go back. This is normal, right? This is normal fovea. There is a dip. Everything looks nice and straight. But these pictures are pathologic, right? So that's not a problem to diagnose. The problem comes when you get scans like this. And let's say this is one scan, and then 2 months afterwards, this is the scan, and then 5 months after. Is this the same? So the answer is I don't know if these are the same. Because right now the OCT technology is relying on my judgment. And that is a very big problem, because there are a lot of diseases that we are unsure how to treat or when to stop treating. For example, if we have a patient with a swelling of their macula and they have diabetic retinopathy, if we go back to this slide, for example, this can be diabetic retinopathy. There is a swelling in the macula, there are big cysts. I treat the patient. The patient comes back. There are still cysts. Okay, I treat them again. There are less cysts. The vision is 20/20, but still there are cysts. Should I stop treating? Should I continue treating? What happens if there are no cysts at all, but the patient still can't see? Should I continue treating? So there is a lot of subjective input. And I can tell you that, from my experience, I come to a patient room and I decide how I'm going to treat him, and it depends upon many things. It depends upon the hour of the day, how many patients I have left, what the fellow said, something I don't like the fellow, so whatever he said, I don't agree. And so it's very, very subjective, and that's a problem. So we started working on this with your cousin Amir, tell him that we appreciate his contribution. And we started working on this with the question of why people that are older, they can't see as well as younger people, even though the inside of the eye looks normal. We look at them, the exam is normal, the retina is normal, the scan is normal, but they can't see well. So why? The answer, well, they're old. Well, yes, but we can't see any difference. So what's wrong? We know that the retina undergoes changes with aging. There are molecular changes, neurochemical changes in the retina. But we wanted to see if the OCT scans can detect changes that explain why people see less. So what we did is we introduced a novel normalized reflectivity scale, which we call an NRS, and basically tried to standardize and give a scale or a number to every retinal layer. And we did this at the beginning at 300 subjects, but then we repeated it with different machines. And time is going out, so we'll not go over the methods, but just show you what we did. So this is the normal OCT scan. We picked a temporal area and a nasal area, and then every layer of the OCT we gave a reflectivity number, but we also standardized it according to the patient's reflectivity. So for example, if the patient had cataract, these are all going to be reduced. And these numbers here are the reflectivity numbers. So this is total reflectivity, and this is the normalized reflectivity scale, which is different. If you normalize, then you see that there are different values for every layer. And the interesting thing that we found is that we could plot these nasal and temporal areas according to graphs, and these graphs, temporal and nasal, didn't really change except for the nerve fiber layer. The nerve fiber layer is the innermost layer of the retina, which nerves go directly to the optic nerve. So in this layer, there is a difference between the temporal and nasal side. But more interestingly, we found significant decline in the nerve fiber layer, both in the nasal side and the temporal nerve fiber layer with age. So the more you age, the less reflectivity you have. And even more interesting is that the ellipsoid zone, this is the zone in the retina that contains the photoreceptor cells, the cells that see the light. These ellipsoid zone, NRS, declines continuously with aging. So we were fascinated by this, but we thought that it's very unreasonable that you're gonna, manually take these area, nasal and temporal, out of each patient and determine something. So we wanted to automate this, and very lucky that Marty introduced me to Ayman and said, oh, this is your guy. He knows how to make it automatic, and yes, he did. So what we did, and I know nothing about this, but Ayman can explain afterwards. He can come here and explain everything. But basically, what we did is try to automate this process to determine reflectivity of every layer. And they developed such a great software that actually can automatically identify 12 different zones in the retina, and this is the most number of layers that was ever identified in an automatic way. So here's an illustration, and you can see especially these lines here are important because this reflects the ability to see. So we had this product, and we said, okay, well, we had the manual data. Let's go and compare the automatic findings to our manual findings. And this is just how they do these things with the color, so nice. And interestingly enough, you have here examples of different ages, patients that are aging, and this is the results of the automatic system. and we found the same thing. Of course, there are more layers that the automatic system can recognize, but basically the same thing. This is the decline in the normalized reflectivity scale. It's mostly in the nerve fiber layer and also in the photoreceptor layers. So this was in complete agreement to our manual findings. So our progress so far was that we have a method that can automatically find and give a number, quantify the retinal layer. So instead of interpreting a picture that is a subjective interpretation, we can get a number and a value for every retinal layer. And we can explain why people see less when they are older, because there is a decline in the nerve fiber layer, but also in the ellipsoid zone. So photoreceptors, if you will, are getting weaker and more scarce. But then we thought maybe we can apply this to something much more important, and maybe we can detect early changes in diabetes. Remember that I told you that the retina may look normal, the OCT may look normal, but there may be a pathology. Now the problem is here that is Holly. Holly is here and she will not allow me to tell anything about this because this is not protected with the patent. So I cannot say anything, but I can just say that what we did is we collected normal OCT patients with and without diabetes with matching ages, and we have certain characteristics of the layers such as reflectivity, tortuosity, angles of the fovea, and thickness. And we are analyzing, compare the normal retina to the diabetic retina. If you look at these OCTs, they look the same to you, right, Eddie? It looks the same?
Yep.
Eddie is our chief resident, so if he says that it looks the same, then it's the same. But if you quantify and give a number, there's a huge difference in reflectivity, in tortuosity, and in thickness of these layers. So what we are hoping to do is getting this technology to be able to be incorporated in the OCT machines that we have today. And in the future, how we envision it is that instead of giving a patient a subjective diagnosis and a subjective discussion, you will get a report. It's much like a blood pressure. You measure your blood pressure, you get a number. It's not like a doctor says, well, it may be high, it's a little bit high, it's a little bit higher than yesterday. No, you get a number. So the same thing we envision is going to happen in the OCT. You're going to get a number, you're going to get a report, and you will know if you have changes in your retina. And hopefully, the treatment ability is going to follow, and you can really prevent blindness this way. The interesting thing is that this OCT machine is now expensive, but prices are declining. So in the future, this OCT machine with this report can be placed in a primary care physician's office, and the patient comes for a diabetic check, gets his eye scanned. The family doctor doesn't know anything about the retina, he doesn't know even if it's normal or not, but he gets a number and he gets a report. This is normal, and then he can say, you're normal, come back next year. So there is not going to be a referral from one doctor to another. On the other hand, if something is abnormal, then he will say, the norm is between 300 and 350, and you are 475. You have to go. So people will realize that there is a need for them to go and get further treatment. So this is how, and I cannot talk to you anything about this because of Holly, so I'm just going to thank you for your attention.
Do you need to leave now, or can we have
No, we can